illustrative. So this is a 64-year-old guy who I had actually seen on an emergent basis. He came into me with an acute thoracic myelopathy, and I treated him emergently with a thoracic decompression. He had a bad spine, but no low back symptoms. But after his thoracic surgery, about 2 years after, he started to develop some progressive groin and thigh pain with left leg buckling during ambulation, and it was so bad that he was actually using walking sticks to walk by the time he saw me. He had 4 out of 5 strength in the left quadricep, but otherwise was okay. His gait was very limited due to his weakness and pain. He did have some pain with internal rotation of his hip. So clearly, to kind of borrow from that classification of hip spine, a little bit of a complex hip spine. Just for completeness, this was his imaging and presentation to me. He came in really, again, with acute kind of urinary retention and a disc herniation that was picked up almost incidentally. Let's see, that disc herniation. So we treated him with a thoracolumbar fusion and a decompression. And he actually, again, I kind of counseled him that he might require a future surgery. He did okay. A couple of years later, he came back. And so this was his x-ray. You can see in the intervening couple of years how the left hip osteoarthritis has really progressed over time. Really both sides, right and left, have progressed over time. And now he's complaining of left-sided thigh pain and quadriceps buckling. So I guess, again, to kind of go back, what would the panelists or the folks in the room, what would you guys do? How would you approach this? Clearly, I think here both, or not clearly, I guess not yet, but anyways, I think there's a contribution likely from the hip for sure, and probably from the spine as well, given the vacuum disc and collapse on the left side here. So how would folks want to approach this? Is there something you would do before surgery to decide which one to do first?
Yeah, first and foremost is the investigate, and then I will, if at all required, then I will prefer spine first than a hip.
I guess we do, yeah. Those are his knees. He's had the left one, and then not a ton of knee flexion there. And from a deformity standpoint, he has a mild sagittal deformity, but he's compensated.
Said he had L2 to L5 laminectomy as well, right?
Yes, he had he's had prior laminectomies from L2 to L5, I believe. Yeah.
And these are his current MRI pictures?
These are his current MRI pictures, correct. Yeah, and bad foraminal stenosis, as you can see on the left there at L2, L3, and L3, L4, and L4, L5 as well.
And that disc above between T9, 10 has been taken care of?
That's been taken care of with that thoracic fusion. And again, like his myelopathic symptoms have resolved. Like he couldn't walk straight, classic myelopathy was the first time he saw me. And so that's all gone. He's better from that. Now it's really groin pain and thigh pain with the progression that you're seeing on these x-rays.
So in your clinical examination, what do you feel is troubling him more?
That's a good question. So I think in this case, this was truly a nice representative case because I think it's a mix of both. There's no question some of his walking limitation is osteoarthritis, but I think the big thing for me here when it came to the consideration piece of this was his quadricep weakness. And so I think as I started to think about this case, whether to do the hip first or the spine first, I think the presence of neurologic deficits, even though it could be pain limited in a case like this, when you get bad hip arthritis, obviously it's tough to clinically examine the quadricep without causing pain. But the fact that he felt his knee buckling, felt or endorsed quadricep weakness, there was some visible atrophy of his quadricep as well, whether it was disuse or neurologic, is open for debate and probably impossible to settle. But I think the presence of neurologic deficit is really what drove me to address the spine first. So that's kind of what we did. I did do an injection beforehand, mostly I think to counsel him on what he could expect after surgery. I think, again, in my mind, there was no question the hip was contributing to his symptoms, but since I was addressing the spine, I would inject the spine and kind of see, at least give him an idea of what he might expect after. And he endorsed about 50 to 70%. Certainly not overwhelming, and so kind of, again, establishes that the hip was causing at least a portion of his symptoms, but it gave me enough to feel confident at least that the spine was contributing. And chose to address the spine first. So this is sort of, again, the considerations I have. I think neurologic deficits obviously override everything, and the presence of neurologic deficits drive us to do spine surgery as spine surgeons. If we do that, then I think that's something we can act on. I think in higher grade deformity, it certainly does make sense to do spine first if you're able to establish that the spine is an important driver of symptoms. But really, it comes down to what is the primary cause of disability. And if it's the hip, I think I would probably send people to get their hip fixed. And if it's the spine, I would send them to get their spine fixed. So in this case, this is what we did. We did this all percutaneously. We're able to do laterals and then SI screws and sort of just hooked into the prior instrumentation. And, he actually, his pain got a lot better, but his walking tolerance got worse. And you can actually see the difference here in terms of his hip flexion, where I think he just, because his pelvis is now locked into place, he has difficulty extending through the hips, probably in a pain-limited fashion. And, I sent him to our arthroplasty colleagues a few months after spine surgery when I felt confident with healing, and ultimately ended up having both hips replaced in a staged fashion and is doing really, really well.